Good afternoon and welcome to UnitedTV. My name is Kamal Erkan. Today is February 9th. Today is our Wednesday, well, it used to be Wednesday wellness webinar, but now it's a Friday wellness webinar. We are going to have our clinical presentations, and I'm going to let our other presenters, panel members in.
I'm here.
All right, now we have everyone. Again, welcome to our wellness webinar. Today, we are going to discuss the diabetes and those patients who are going through bariatric surgery or who are dealing with morbid obesity, the way that they are managing their diabetes, and things can be done from the morbid obesity standpoint and how they're actually managing their diabetes. So because of the topic itself, we invited Dr. George Ibrahim from CRIAS. He's one of our bariatric surgeons, and also our one of our dietitians, Beth Wright, is going to be with us. And Donna Gunkel is our program director. She's the director of clinical integration. She's with us. So guys, how are you doing?
Hey, Kamal, how are you doing today? Thanks for having us.
Thank you.
Happy to be here.
So we can start the presentation. So I'm going to actually, this will be part of whom is going to be with PowerPoint, and there will be some question answer format. So I will bring this up.
All right. So, well, thanks again for inviting me today, Kamal. This is very, very important topic for us surgeons. Of course, for our bariatric patients, and generally speaking, in fact, for any surgical patient. So a lot of that applies also if you're doing general surgery, like hernia surgery, gallbladder, etc. Now, having good control before an operation is a must, because uncontrolled diabetes can result in a lot of adverse outcomes and complications, bone wound healing, infections, and even staying longer in the hospital, and God forbid, even cardiopulmonary events. Now, there's a very important point we need to look at here, make a very, very clear distinction. A lot of people think controlled diabetes goes around hemoglobin A1C values. And that might not be the case really, because hemoglobin A1C is meant to see how you're doing over a prolonged period of time, 3 to 4 months. So you might have an elevated value 3 months ago, but the last couple of weeks you've been doing really well. So that's why when we really talk to patients about how their blood sugar has been or how their diabetes has been the last few weeks, we look to the numbers. And when you hear numbers like 300, 200, 250, then that doesn't indicate really good control, even if you have hemoglobin A1C 6.7, for example. So it's very, very good point here to understand the difference between this and that. And what you're really aiming for before the surgery is to have good control on the blood sugar numbers themselves, not just the hemoglobin A1C. Even in the literature, when you do extensive search in there, you'll see that relation between blood sugar and outcomes is very more established than just hemoglobin A1C as a marker. So our focus here today will be on the blood sugars, not hemoglobin A1C. We can move on to the next slide, please. Okay. Now this goes in fact into 3 steps or 3 phases: before the surgery, during the surgery itself, and after the procedure. Most of the work, in fact, or the effort goes before the operation in the preparation process, because once you have good control before the surgery on blood sugar, it's very easy to maintain that control during and after the surgery itself. So this is why it's not just one-man show here. It's a multidisciplinary approach between surgeons, dietitians, and the medical colleagues, whether they're primary care doctors or endocrinologists. As you see, diabetes, in fact, has been treated for hundreds of years now. There's a lot of medications. I just listed some of the families of medication, not even the names. It's a very long list of options to treat diabetes. So this is why it's a lot of interaction between us, patients, and medical doctors and the endocrinologist. During our initial consultation with bariatric patients, we emphasize on that if they have the history of diabetes, they need to start immediately making sure it's under very good control, trying to have them at least in the range of 80 to 180 milligram per deciliter for a few weeks before the surgery. And again, I'll go back to the point of hemoglobin A1C or fructosamine. Some insurances require to have these numbers in certain ranges before proceeding with surgery, but in reality, they are not really of clinical importance as long as the patient have really at least 2 or 3 weeks before surgery had good control. Another consideration for bariatric patients is the transition to surgery itself. Around 2 to 3 weeks before the operation, we start them on high protein diet, low carb intake. They can have around 120 grams of protein per day, but maybe under 20 grams of sugar. So if they continue on the same intense control of diabetes, they're at risk of hypoglycemia. So during that period of time, they might need less medications. And again, we reiterate that with the medical doctors, endocrinologists, and the patient themselves. We just warn them against that and just keep an eye on it and keep your medical doctor involved with any changes. Maybe a little bit exception to this is type 1 diabetics. You cannot really go very low on carb content, otherwise you're at risk of diabetic ketoacidosis. So we allow them a little bit more carb, but still within certain amounts. Another consideration is the current or the newer medications to treat diabetes. In the last few years, there have been newer medications introduced, like, for example, Ozempic and Wegovy, Manjaro, or what we call GLP-1 agonist. Now, one of the ways these medications work is by slowing your GI tract transit time. See, when we eat or drink anything, it's been some time within our stomachs. And sometimes this medication can prolong that. So what happens is when you go for surgery, you have to be fasting because there's risk of aspiration. And if you take a medication slow in your stomach, that risk goes higher. So these medications has to be stopped before the operation. Now, of course, every medication have its own half-life. So some of them need to be stopped a week before or a few days before, depend on how they last in your system. So during that period of time, you might find yourself that you need alternative. Otherwise, your blood sugar might not be very well controlled around the surgery time. And again, that's something we do in coordination with the medical doctor or the endocrinologist. We can move on to the next slide, please. There's just a list of these medications from that family in particular. And as you see, there's a lot of them out there on the market. And again, depends on their half-life. You either start them a day before or a week before. And again, that's just something we discuss with the patients, explain them the risk of anesthesia with aspiration if they have still food or liquid in their stomach, and we stop the medication in proper time. But the most important part here is the transition maybe to another medicine or insulin to make sure they still have that good control before the surgery. Another slide also, there's another family of medications where we need to stop them before the surgery, and not for risk of aspiration, but the risk of DKA or diabetic ketoacidosis. On the next slide, you will see that medication family. We call them sodium glucose cotransport inhibitors. And the problem with these medications, they can, with the stress of surgery, you can find your patient having diabetic ketoacidosis, especially if you're having a surgery that will last more than an hour. The patient had to be MBO, fasting for almost 12 hours, especially if the patient is not the first case in the morning, like his surgery scheduled for noontime. Hemoglobin A1C has been above 8. Blood sugars controlled, but not optimum, very optimum, has been on insulin or high dose of insulin. So in those situations, those patients are at higher risk. So generally speaking, our field is elective. So we have time to stop these medications, switch them to something else. So the transition to the surgery day is smooth and you don't have fluctuations in blood sugar, and you minimize the risk of decay as well. We can move on, please. I just listed some of these medications. Again, there's a lot of them out there combined with other medications. It's quite extensive list, as you see. And again, based on their half-life or how long they last in your system before they're metabolized, some of them need to be stopped 4 days before the surgery or 3 days. So just wanted to put that out there. If you see any of your patients or yourself on medication like that, then you have to stop that. And again, you keep your eye on your blood sugars. Family doctor or endocrinologist can stay in touch with you and see how your sugar is faring, and we can adjust with other medications if needed. We can move to the next one, please. Now, this is pretty much the first phase before the surgery, and you see there's a lot of considerations. But once you go for the surgery itself and you already have achieved that adequate control before, maintaining it during the operation is not that hard. We just keep checking your blood sugar during the surgery, before, during, and after, of course, on the day of the surgery. And if we need to do any corrections, we use short-acting insulin, usually given by subcutaneous route. And most of our bariatric surgeries now, in fact, are short, like lasting 1 to 2 hours max. Most of them are outpatient. So that phase tend to be, in fact, very brief. Then we move on to the next phase, or step 3, which is after the surgery. And that starts from the recovery room. After the surgery is done, you settle down in your bed in the recovery room. We check your blood sugars again, make sure they're okay. And if we need to do some insulin here and there, we do that. But by end of the day, when everything is stable, your blood sugars are in good shape, we discharge patients home on the same regimen they had immediately before the surgery, because most of the bariatric patients will go home on liquid protein diet for another 2 weeks. So pretty much will be the same level of calories they're getting and carbs. So pretty much what worked before will probably work after. And during the follow-up after the surgery, pretty much we see how things are, and we keep again communicating with endocrinologists, primary care doctors to make sure that transition as we advance diet, they also be transitioned during their diabetes medications. And I think that's all I have for today. Thank you.
Thank you, Dr. Ibrahim. Just so that everyone is kind of able to follow, you explained this very well. So the one interesting thing is 95% of everything that we need to do has to be pre-surgical. So all the stuff that we need to prep the patients, and I know we work with our, I mean, as you know, with the case conferences, and our care coordinators are working with our patients. But you mentioned that this is not only for bariatric surgery, but other surgery, other general surgeries. This is a risk factor, even if they are getting gallbladders or hernia. The diabetes is something that we need to take under control for the risk factors of, the delayed wound care, wound healing, increased rate of infection, and the longer hospital stays. So those are important. But what's interesting to me is this is in many cases. What I find out in our case conferences for patients who are going through the bariatric surgery process, they don't even know that they have diabetes. So all of a sudden we have a patient with A1C 9, 10, 11, 12, up to 15. And my initial reaction is going to their primary care to see if they were actually ever diagnosed. So because we want them to work with their primary care first, but in some cases the number is so high that they need to see the endocrinologist right away. And one other thing that I want to mention is the utilization of fructosamine is very little, other than, I guess, the surgical. And I know from primary care standpoint, it's not being used a lot. And the difference between the A1C that's giving us the average of the last 3 months versus the fructosamine is giving us the last 2 weeks of what's happening with the patient. So that way, because sometimes I see the mistake of patient looking at their A1Cs, saying that it's so too high, but then when we look at the fructosamine, that actually is much better controlled because that's giving us the, if we start treating the patient 6 weeks ago, we may not be able to see everything on the A1C, but fructosamine will show us what we are looking for. So we'll come back, and then there will be maybe some more questions. So I'm going to have Beth to tell us how actually manage the blood sugar before and after surgery for those patients who are going through the bariatric process. And again, I'll do my best with the next click. So
you got it. Thank you, both Dr. Ibrahim and Kamal. Yes, so as you heard, I'm Beth Wright. I'm one of the 5 dietitians that CREAS has in its employ to work with all of our patients. The dietitian is somebody that you see pretty regularly through your lead up to surgery, typically at least for 3 sessions, sometimes more if we need it. And we are working basically because of what Dr. Ibrahim pointed out and Kamal also pointed out is 95% of the kind of the preparation work is done ahead of time. And so the dietitian is very much involved with that with our patients. So we're really kind of focused on healthy weight loss, but also how do we get there? So here, I just put down a number of very important topics that we talk about with patients as dietitians. So these types of patterns do help patients maximize their healthy weight loss, but in addition, they also are pretty integral in the management of blood sugars as well. And we're going to go through each of these in the next couple of slides and talk a little bit more about them in depth. So to simplify what this slide says, basically when we are in a high stress state, a lot of the time, our body goes into kind of a version of fight or flight. And what that does is it makes our hormone balance rather topsy-turvy, and our blood sugars can tend to rise with high stress. So a dietitian, if they're sensing or told by their patients that they have a very high stress lifestyle, whether it's personal life or work life, we do try to make some suggestions on things that we think might be helpful for reducing the amount of stress and then hopefully reducing blood sugar levels. So it could be anything from suggesting things like yoga or breathing techniques or scheduling short breaks for yourself, maybe going to cognitive behavioral therapy. We also indeed work with patients on learning how to set goals to break things down into smaller, more manageable chunks, because a lot of the health practices that we have people engage in, they can seem a little overwhelming at first. So we talk with patients about how to kind of build up to things so that maybe their stress isn't as high, figuring they have to figure out everything overnight. And go to the next slide. So when most of us think about weight loss, we tend to acknowledge that exercise is a key component of weight loss, but it's also very integral to blood sugar management as well. And as this slide details, physical activity can be a major component of helping to reduce blood sugars and of course the A1C over time. One thing we want to do though is to make sure that our exercise isn't bringing on blood sugar lows, or if so, we want to be aware of that and then make sure that we have things on hand to remedy that. So a general recommendation, and Dr. Ibrahim, jump in if you have a different number in your head, but we kind of tend to say if your blood sugar levels are below 100 before a workout that's probably more than a couple of minutes, we would suggest that maybe you eat a little healthy carbohydrate before you have your workout. It's also, if you can, recommended maybe about a half an hour into the workout, if you can, especially if you have a continuous glucose monitor, check to see where your levels are to make sure you're not tanking. And then we also recommend testing, after you work out, especially if it's a particularly strenuous exercise and you might need to take a kind of a recovery snack afterwards. If you're taking insulin, just of note that the risk of developing hypoglycemia may peak at around 6 to 12 hours after a workout. So you just kind of have to be aware of that. So you might want to time your workouts to not have that maybe happen in the middle of the night, for example. Next slide. So sleep has a relationship with many, many health issues. including weight management, and blood sugar management. So when one doesn't get adequate sleep, it can prime the body and the brain to consume or crave more high carbohydrate, high calorie type of foods because of the hormone imbalance that's happening. And this in turn can raise blood sugars potentially. So we do tend to recommend trying your best to get somewhere between 7 and 8 hours of sleep a night so that your body can go through all of the processes, the cycles that tend to balance out your hormones. And so a couple of the what we call sleep hygiene techniques that we work with patients on are things like doing your best to avoid screens at least 1, hopefully 2 hours before bedtime. That includes TV, handheld phone, computer, those kinds of things, because the light that emanates from those things can actually invigorate and keep us up a little longer, even though we eventually will tire out. We talk about maybe taking like a hot warm bath or shower to kind of relax your body, maybe engaging in something like yoga, meditation, or even reading an actual book, or listening to relaxing music, just again to try to get your body ready to enter into those into a good deeper sleep. Go ahead. So in addition to working with patients specifically about what foods to eat more of and what foods to not have as often, we also do kind of work behind the scenes as well. We talk a lot about some of the thought patterns that surround food, because we all come with a history of a relationship with food, and it can be influenced by many, many, many things. And so we do talk about some of those things during our session, and also sometimes then we also encourage people to speak with behavioral therapists if they want it, it seems like they need to dig a little bit deeper into their food patterns. We also do talk a lot about setting up your home environment for having more success with meeting your particular health goals. So as this slide points out, our brain is working many times. I know at home, I have this little placard that says, my brain has way too many tabs open right now. And that's because we have things, both our conscious thoughts, which were like our active thoughts. Like right now, I'm thinking about what's going to be on my next slide, etc. That's forefront in my brain. But there's also things in the back of our heads that are also usually going on as well. And those can also affect our choices. So we do talk a little bit about that with patients as well. We also talk about how things in our life can become quite patterned, and some patterns are really important for us, but others we might want to take a look at because they're not as healthy for us. So things like, just what portion sizes are we used to consuming? Well, maybe it's not necessarily because we're paying attention to what our body is telling us that it's full before we eat that full plate. So we do talk about kind of listening and becoming more mindful about signaling and cues that your body gives you, not just eating particular amounts and types of foods just out of habit. We also definitely suggest, again, making sure that treat foods in the house aren't the first thing that you see all the time. And I'll give the example of, and I'm sure that many of you have had this experience where, let's just say I am walking from one room through my kitchen to get to the room that has something that I've printed out something, and I'm going through there to get the printout. If I happen to glance over and see on my kitchen counter the fresh baked cookies or pretzels, now all of a sudden I want fresh baked cookies and pretzels. Whereas, hey, before that, I wasn't even thinking about that. I was going to get the printout. So we tend to eat what we see. And so working with a dietitian, we will tend to have you do things like treat foods maybe for other people in the family, put them behind things in the refrigerator, kind of put them behind things so that your brain isn't even kind of working on that unconscious level saying, ooh, I want that. And then we do talk about doing things like setting up purposeful cues. So it's not only about hiding or stashing away foods, but it's also about putting forward foods that are helpful for your health and liquids. So I often have my patients, set out water bottles, and I'll have them set out 4 water bottles and know that visually in a place that they go through often during the day, and that gives them a cue of, oh, wait a minute, I haven't sipped in a while and I need to try to get these 4 bottles in today. So that's a visual cue, something like that. You can do things like prep some snacks, and when you open your refrigerator, you've got the hummus and already cut up vegetables right there. It's a visual cue of, if I'm hungry, that's what I can grab. So the key theme here is intentionality. So we want to help guide our patients into those kinds of patterns so that it can support this overall goal of eating healthier, managing blood sugars, et cetera, before and after surgery. Okay, next slide. So the bottom line here is that our metabolism likes a fuel source. So our bodies need fuel or energy or calories. Those are all the words for the same type of thing. And I like to use the analogy of a car. So our bodies need fuel just like an automobile needs gasoline to function. If we take that analogy a little bit further, let's just say that our bodies are like beautiful, expensive cars. They're not just, the junkers, they're the Jaguar or something like that. And they require premium fuel to work really well. Otherwise, the engine not really happy with us. So our bodies are similar. So we have to focus on kind of the amount of fuel we're putting in and the type of fuel we're putting in, just like with that car. If we don't give that car gasoline enough, it's going to start to, run out and not have enough energy to keep driving. Same thing with our bodies. And when we don't give ourselves a continuous source of fuel throughout the day, we can tank our blood sugar levels. And we'll go into that in a minute. But so when we don't fuel our bodies with appropriate types of combinations of food or frequently enough, we can start to get negative side effects like you see listed on this slide, just kind of the brain fog and fatigue. And of course, it can get more serious too, of even losing consciousness if you don't get enough in, especially for like type 1. So the bariatric dietitians, as we said, we work with patients both before, and we do see patients afterwards, at least for 1 session. And then I always tell patients, if you want to see me again, let our organization know and we can follow up with you. So what this tends to, what we were talking about earlier is of the quality of what we put in our bodies can affect both our healthy weight loss and our blood sugar levels. So we're looking for a balance of nutrients because each of the nutrient types tend to have a different role in the body and then some intertwining roles in the body. So for example, in this picture on the left hand of this is kind of a before surgery healthy eating pattern. And we encourage people to get in a lot of those vegetables. Vegetables are our volume food. That's the one we want to eat the most of because it's low in calories, but it's loaded in fiber. And we'll talk about fiber in a minute with blood sugar control. It's loaded with vitamins and minerals, as we know, antioxidants. The other half of the plate we see divided into quarters. So, for example, the protein portion, That is something that is very much emphasized after bariatric surgery because we want to try our best to minimize weight loss coming from the loss of muscle. And one of the best ways to do that is to make sure that we're getting enough protein sources through our mouth, so that our body doesn't have to break down muscle in order to get the protein for our cellular functioning. And then carbohydrates are our body's preferred fuel source. So some people are like, oh, I thought all carbs were bad. It's like, no, they're not bad foods, but they are the ones that we do want to watch the portion of very specifically, because we want enough that we keep our blood sugars level, but we don't want so little that our blood sugars go down, or too much where they go up. So go ahead to the next slide, and we'll talk a little bit more about that. All right, so, oh, and I think it jumped. Can you go back, maybe? There was one slide in between there. One of my slides disappeared, apparently. That's all right, we can jump to this one. So, as Dr. Ibrahim mentioned earlier, dietitians, we do pay attention to a number of the markers of how people's diabetes is controlled or not controlled. So we'll ask them, are you checking your blood sugars on a regular basis? What are the numbers? What time of day do you take them? So we can get an idea of what might be influencing those numbers and can help guide patients that way. We do take a look at the A1C just to kind of get a history of where are they coming from, and then also check to see maybe if there are some fructosamine levels that we can look at. Generally, we're happier if we see an A1C below 8, because that tends to indicate that the blood sugars are close to being where we want them to be before surgery. All right, next slide. So I like this slide because it gives a visual depiction of what I mentioned earlier, that the quality or the combination of foods that we eat in meals and snacks can really affect what our blood sugars tend to do. So as you can see, and I'm not going to go into too much detail, but you can see this red line here that goes way up and then comes down pretty quickly. That's in general what we want to avoid. So for example, what might have been consumed before that caused that big spike and then drop is a low fiber carbohydrate food. But we find, let's just say you're still going to have that food. If we add other nutrients to that eating event, we will start to see blood sugars tend to not spike and drop as quickly, because that quick drop also sets you up for more craving to eat more quickly because you're low blood sugar. So if we go all the way over to the right-hand side, where you look at that light blue line where your blood sugars are rising slowly and then slowly coming down, I call it the rolling hills effect. That's kind of ideal, because what that does is that slow rise from your blood sugar, we've added things that slow down the breakdown or the release of blood sugar into from the stomach into our bloodstream by adding things like protein or high fiber or healthy fats. So that's how we get this more slow rise, because the blood sugars are being released into the blood more slowly because they have to deal with all these other things that take longer to digest. Then when blood sugars start to go down, it tends to go down more gradually, which tends to mean that we're not ravenously hungry right away. Therefore, we're not necessarily snacking all the time and potentially raising our blood sugars through that. So, next slide. All right, to sum it up, we've kind of gone through all of these healthy patterns that we work with patients on before surgery, but that they're equally important after surgery. But as Dr. Ibrahim pointed out, also medication management is key at this point, because not everything can just be managed through what you're eating and drinking for a while. It needs to be addressed with typically lessening medication levels. I think that's all I have today, unless there's any last minute comments or
You did
questions.
You did really good. So I have one, I don't know if you missed it or maybe I missed it. So I just want to make sure I ask or we address this with Dr. Ibrahim. Patients' diabetes status would also impact our choice of surgery type, right?
Well, I
That's
mean,
Dr.
there's
Ibrahim.
yeah, I mean, there's some controversies in medicine. We know losing weight by itself does improve a lot of diabetes. But here's the thing. I mean, there's different bariatric options, sleeve, gastric bypass, the duodenal switch. And there's been comparison studies to compare which one is more potent against diabetes. But what we know is if your diabetes is relatively young, meaning I was just diagnosed with diabetes 6 months ago, then the odds are it will get better with any choice, really. On the other hand, if I've been 20 years diabetic, the odds are that diabetes completely disappearing from my life is less and less the more I've been diabetic for years and years. But let us talk about the gray zone, 6 to 8 years. Like let us have been diabetic for 6 years. So the more aggressive the surgery, the more the chance of having better control or putting diabetes in remission. So by aggressive surgery, I mean something like duodenal switch and gastric bypass comparing to something less invasive like sleeve gastrectomy. But you also have to look to a balance between my goals and, let us say, a side effect of aggressive surgery. Because there's certain things, like for a bypass, for example, there's some medications they cannot take. For duodenal switch, for example, there's high risk of malabsorption, anemia, vitamin deficiency compared to sleep. So, I mean, I think that becomes, at this point, if you are in that gray zone, one-on-one discussion with the patient and their provider, and you just outline the benefit and the risk. And the unique thing about bariatric surgery, the patient opinions really matters more than anything else. I mean, if I have an appendicitis, there's no really opinions. I need my appendix out. Okay. But when it comes to bariatric surgery, it's elective and patient understand what are my options? What do I get from this one compared to that one?
Thank you, Dr. Ibrahim. The other thing is that you mentioned with the sleep patterns and issues with the sleep and the complications, and we actually discussed in our providers meeting yesterday. Once again, those patients without the sleep apnea treatment, how life can be a little bit more difficult for them, or also managing the other comorbidities can be more complicated. So that's something that while we are going through this process, we are actually addressing a lot of other issues that's not directly in morbid obesity, but it is part of morbid obesity. So it does help us to identify and diagnose a lot of other issues where we can address them ahead of time, which impact the better outcome for those patients.
The analogy I like to use with both my weight management patients, but also just with my diabetic patients is a lot of these things, if you kind of look at it like a pie chart and you know how there's those wedges of different topics or things, all of this is affected by many different things. And some of those pies we don't have much control over, like our biological heritage. It is what it is, right? So we can't, so we focus on things that we do have a little bit more control of, like the choice of the foods that we eat and how much exercise we do or don't get, and sleep patterns. Some of it's in our control, some of it's not in our control. So yes, we work the best we can so that those wedges don't get in the way of our health.
Exactly. All right. Donna, did you have any questions?
Well, it's not really a question, but I was going to comment because, again, to your point about last night, I think sometimes we tend to look at the different illnesses or disease processes in a silo, and we try to look at that whole picture. So again, that's why it's important that we have, you know, both from the surgical side as well as many specialists and the dietitian to be involved in this. And I agree with Dr. Ibrahim. I think taking this perspective and knowing it's not just for bariatric patients, but for any surgery, because one of the things we've learned from Dr. Hundle many times is that patients may feel okay with that high A1C, as Kamal mentioned earlier. They don't know, right, until they go to have it tested. So again, it kind of comes back to the overall health and getting that physical and getting your blood work done annually, so you know that, because patients do become used to the blood glucose levels increasing over time. It doesn't go from 6 to 15 overnight, right? So making sure that the patients realize they don't have to feel bad, right, to have things that are affecting their bodies. And so we want to help them be preventative instead of reactive. And I think that's part of our whole approach when we do these webinars.
Exactly. All right. Anyone, anything you would like to add before we close?
No, thanks so
No,
much for having us tonight. It's a very important topic, and I'm glad we had the opportunity to discuss it today.
All right. Well,
yeah, and I just
ahead.
jotted a couple notes of some things that Dr. Ibrahim said that I hadn't heard before, so it was very informative for me as well.
Thank you.
Thank you so much for joining us as a guest speaker for today. Beth and Donna, thank you again. So we'll have our Bariatric Friday in 10 minutes. Dr. Irga is going to join me, and we'll be back with other events. Until then, have a great weekend. We'll see you soon.
Thank you.
Thank you.